யூடியூப் இல்லைன்னா ஃபேஸ்புக்கில் போட்டு ஃபேஸ்புக்கில் யூஸ்
டிஸ்பிளே ஆகும்.
அவ்வளோதான். அப்போ இந்த லிங்க் நீங்கள் போய் ஓப்பன் அப்படி ஓப்பன் யூடியூப் இல்லைன்னா ஃபேஸ்புக்கில் போட்டு ஃபேஸ்புக்கில் யூஸ்
டிஸ்பிளே ஆகும்.
Excuse me. YouTube link எங்க இருக்குங்க சார்? ஹலோ சார், யூடியூப் லிங்க் எங்க இருக்கும்? அந்த லிங்க்
சார் சாட்ல ஷேர் பண்றோம் சார்.
லிங்க் ஷேர் பண்ணுங்க. யூடியூப்ல கனெக்ட். யூடியூப் லிங்க் எங்க இருக்குங்க சார்?
சாட்ல ஷேர் பண்றோம்.
ஹலோ, யூடியூப் லிங்க் எங்க இருக்கும்?
சேட்ல பாருங்க.
சாட்ல ஷேர் பண்றோம் சார்.
லிங்க் ஷேர் பண்ணுங்க. யூடியூப்ல கனெக்ட். யூடியூப் லிங்க் எங்க இருக்குங்க சார்?
இப்ப ஷேர் பண்றேன்னு சொல்றாங்க. அது கொஞ்சம் வெயிட் பண்ணி பாருங்க.
எங்க இருக்கும்?
சேட்ல பாருங்க.
Hello. Hello. Am I audible? Hello. 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 I am Dr. Anand Chokalingam, the Faculty Secretary of CGP. Very sorry for the delays. We had some starting hiccups today. I would like to welcome you all for the first CME by our new team. So the first speaker is Mr. Dr. Ravi Shankar, an associate professor from MMC. He is going to speak about the waterborne diseases here. Last minute, we had a change in the speaker in this. Sir, Ravi Shankar, sir, you can start the meeting, sir. Sorry for the delay, so that we had some starting hiccups. So at 4:30, we'll have the inauguration, sir. First, you can proceed with the meeting, sir. Thank you, sir. Yes, sir. Yes, sir. On. So, Ravi Shankar, sir, a moment. Can you spare a moment, sir? I will tell about the IMA prayer and physician's prayer, sir, before the meeting. Yes, sir. Thank you, sir. Okay. May IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Physician prayer, dear Lord, those Ravi Shankar, sir, I can start. Sorry for the delay, sir. Sir, am I audible, sir? Yes, sir. We are able to see the view, sir. Yes, sir. Thank you, sir.
ஸ்டார்டிங்ல கேட்டுச்சா சார் நான் பேசுனது? இனிஷியலா ஸ்டார்ட் பண்ண அப்படியா? ஓ, சரி. அக்யூட் ஆகுது சார். ஆனா அக்யூட் ஆகுது. ஆனா அது நான் பேசுறது கேட்கக்கூடாது. நீங்க பேசுனது தான் எனக்கு விட்டு விட்டு தான் சார் கேட்டுச்சு. இது கேட்கும்போது நல்ல சவுண்டா கேட்டுச்சு. ஒரு செகண்ட். வேற சிஸ்டம். ஒரு செகண்ட். அதான் சார் எனக்கு நான் வீட்டில் ஆகும். நான் ஃபர்ஸ்ட்ல இருந்தே அன்மியூட் பண்ணியிருக்கேன் சார். இப்போ அன்மியூட் தான் பண்ணி வச்சிருக்கேன். ஃபர்ஸ்ட்ல இருந்தே பேசுனது கேட்கலையா? அப்படியா? நீங்க பேசுனது நல்லா கேட்டுச்சு சார். ஓகே. ஆ ஆ, ஹலோ
Hello, sir. Tell me, sir. Now you are audible.
இப்ப கேக்குதா சார்?
இப்ப நல்லா கேக்குது சார். இப்பதான்
ஓகே.
கேக்குது சார்.
மைக் எடுத்தோம். ஓகே சார், ஜஸ்ட் மினிட் சார், ஸ்கிரீன் ஷேர்.
Okay, please.
Hello.
Yes, sir. You're audible now, sir. Please, sir.
Yes, sir. Good evening, all. I am Dr. Ravi Shankar, working as Associate Professor in Medicine in Madras Medical College. And today, the objective is, today we'll speak about waterborne illnesses, typhoid, jaundice, and acute gastroenteritis. Enteric fever, otherwise called as typhoid fever. It was called as typhoid fever because it resembled the typhus fever. And the name enteric fever was proposed in the year 1869 to differentiate it from typhus fever. But actually, enteric fever is a misnomer because it is not an infection which is confined to the intestine. It is a systemic infection. It is just the route of entry is the fecal-oral route through the intestine. And the etiological agent, we all know, Salmonella typhi, Salmonella paratyphi A, B, and C. The transmission is through the fecal-oral route, through food, water, raw fruits and vegetables, shellfish, oral sex, and insects like cockroaches. And Peyer's patches of the ileum and the cecum is the first target of this bacilli. These Peyer's patches get infected with this Salmonella bacilli, through which it enters the bloodstream. The pathology, the first week it enters the blood through the intestine and causes a bacteremia. In the second week, it becomes widespread and enters the reticuloendothelial system. And the second week, it enters it becomes widespread and involves the reticuloendothelial system, and it causes focal necrosis of the liver, and it involves the spleen. And the third week is the most important week because that is the week of complications, and it will cause ulceration of the Peyer's patches, and it may cause intestinal bleeding and perforation. And beyond fourth stage, the infection will become chronic. It colonizes the gallbladder. It forms a biofilm around the gallstones, and the patient becomes a chronic carrier. Yes, the clinical feature, the most common clinical feature is the fever, and it will present as an undifferentiated fever in 75% of the cases because there will not be any localizing signs, and patient will have headache, chills, sweating, arthralgia, and myalgia. And the next common symptoms are the abdominal symptoms, abdominal pain, anorexia, nausea, vomiting, and diarrhea. And sometimes when the Peyer's patches becomes hypertrophied, it may cause obstruction, and patient can present as with constipation. the stepladder fever. As conventionally taught, the typhoid fever will cause a stepladder pattern of fever. That means the fever temperature will become more and more every day, and it will form a stepladder pattern. And in this antibiotic era, and we treat the patient immediately with paracetamol and all. So the stepladder fever is seen only in 12% of the patients nowadays. And other clinical features include hepatosplenomegaly, rose spots, coated tongue, abdominal tenderness, and relative bradycardia. So the rose spots usually occur in the end of the first week and the starting of the second week. It will disappear in 4 or 5 days. It is mostly concentrated around the trunk and over the chest. And the rose spots are actually due to the direct invasion of the bacilli. It is not an immunogenic reaction. It is due to the direct invasion of the bacilli. One interesting thing about rose spot is, if you take a punch biopsy of the rose spot, you could culture the Salmonella bacilli from the rose spots. And the coated tongue. Coated tongue is considered as one of the common features of typhoid infection. And the coated tongue is due to long-standing dehydration due to high-grade fever, which causes decreased salivary secretion, thereby clearance of the debris in the tongue. And relative bradycardia, that is, for every degree of increase in the temperature, there should be an increase of pulse about 10. So the relation between temperature and pulse increase is 1:10. But here, there will be a relative bradycardia. That means the pulse will not increase in proportionate to the temperature. So this dissociation is called as relative bradycardia. And the relative bradycardia is called as Faget's site. Faget was the first person to identify that relative bradycardia. And this relative bradycardia is not specific for typhoid infection. Many infections and many non-infectious causes can also lead to this relative bradycardia. The complications will occur in the 3rd or 4th week of fever. Gastrointestinal bleed is the most common complication, which occurs in 6% of the patients, and perforation can occur in 1%. Guillain-Barré syndrome and neuropsychiatric manifestations are rare complications of typhoid infection. Coma vigil is a rare neuropsychiatric complication of typhoid infection, in which the patient will be in coma state, but yet the eye will be open. That is, the patient will be in a persistent vegetative state. And muttering delirium, that is, the patient may be in delirium, will be in delirious state. He will be pulling the blankets of the bed, and he'll be trying to catch some imaginary objects there. So that is a muttering delirium, which is a feature of a neuropsychiatric manifestation or complication of typhoid. The diagnosis of typhoid fever is done by isolation and culture. Isolation by culture. The blood culture will yield 60% of the, will give an yield of 60%. Bone marrow will yield 80%, but this is an invasive procedure. Duodenal secretions, stools, and urine can also be cultured, but the yield will be less. Though blood culture is the gold standard, the sensitivity of the blood culture is less. So Buffy coat culture. If you centrifuge the blood, it will get separated into 3 layers. The lowermost is the erythrocytes, that is the RBCs, and the uppermost is the plasma. And in between the plasma and the erythrocytes, there will be a Buffy coat, which is rich in platelets and the monocytes and lymphocytes. So these typhoid bacilli will be more concentrated in these monocytes and platelets. Therefore, culture of the Buffy coat will give you a better yield. Duodenal string test is a non-invasive test to take biopsy from the duodenum, and this is the duodenal string, a capsule attached to the to a string, and the patient is asked to swallow that capsule, and it will it will attract some duodenal secretions and it will be pulled out and it can be sent for culture. Vidal test, though Vidal test is the commonly used test and the most useful test for typhoid infection, it is less specific and less sensitive for typhoid management. Yet, due to its easy availability and non-invasiveness, it is widely used. So, how to interpret an Vidal test? Remember, typhi O, there are four titers, antibody titers will be available. Typhi O, typhi H, paratyphi H, and paratyphi HA and paratyphi HB. 4 will be available, of which typhi O speaks about the recent infection, typhi H about the old infection, and there is no such differences in the paratyphi. So, if all the 4 are less than 40, you could consider typhoid as negative. If any of the 4 is more than 40, you have to repeat the test, Vidal test after 1 week to observe a 4-fold rise in the titer. If the O is more than 80, it could be early typhoid. But if the H is more than 80, but the O is less than 40, then it could be a old typhoid infection. Any one of the 4 more than 160 is suggestive of typhoid. Both O and H more than 160 or any one more than 320, it indicates a significant typhoid. So, to call it as a typhoid infection, the H and the O both should be more than 160 or any one of the 4 should be more than 320. So, this is the way to interpret a Vidal test. And treatment can be summarized into 3 categories: empirical treatment, treatment for fully susceptible strains, multi-drug resistant strains, treatment for multi-drug resistant strains. Empirical treatment, azithromycin, remember the dose of azithromycin, it is not 500 mg BD, it is not 250 mg BD or 500 mg OD, it is 1 gram OD, that is either 500 milligram BD or 1 gram OD per oral for 5 days. Or if the patient is admitted as inpatient, ceftriaxone 2 gram IV can be given for 14 days. And for fully susceptible strains, azithromycin 1 gram OD for 5 days or ciprofloxacin 500 milligram per oral for 7 days. And the multi-drug resistant strains can be classified into fluoroquinolone resistant strains and ceftriaxone resistant strain. And for the fluoroquinolone resistant strain, azithromycin, and for fully susceptible strains, azithromycin 1 gram OD. So the MDR multi-drug resistant strain, the fluoroquinolone resistant strain, the treatment is azithromycin 1 gram for 5 days or ceftriaxone 2 gram for 5 days. For ceftriaxone resistant strains, instead of ceftriaxone, you can use a meropenem 1 gram IV TID for 14 days. So if you see, for all the strains, empirical, fully susceptible, fluoroquinolone and ceftriaxone, azithromycin 1 gram per day per oral for 5 days will be a useful treatment. And typhoid carriers, about 1 to 5% of the people who are infected with Salmonella typhi will become asymptomatic chronic carriers, and the carrier state may follow acute or mild illness or subclinical infection. Females, infants, and person with biliary tract abnormalities are more prone to become typhoid carriers. We all know about typhoid Mary. She had his career as a cook and she transmitted her infection to 122 documented patients. So she is a carrier of 122 cases, of which the documented death is about 50%. So she was considered as the most dangerous female or woman in America. Eradication of carrier state can be done with ciprofloxacin 500 milligram BD for 28 days or amoxicillin 2 gram TDS for 28 days. typhoid vaccine. There are two vaccines available for typhoid. One is a conjugate vaccine, another one is a polysaccharide vaccine. The conjugate vaccine can be given for all children above 6 months to adults less than 45 years. It is a single dose vaccine. Whereas the polysaccharide vaccine is given for all children 2 years above. There is no upper age limit for this polysaccharide vaccine. And the booster should be given every 3 years. Next, the gastroenteritis. Acute gastroenteritis will present with two different clinical syndromes. One is a watery diarrhea syndrome. By definition, watery diarrhea is frequent passage of watery stools, that is more than 3 stools per day, or dysenteric diarrhea, that is passage of blood and mucus in stools. The etiological agents, common etiological agents of watery diarrhea are viruses, adenovirus and rotavirus, and enterotoxigenic E. coli, enteroaggregative E. coli, and Vibrio cholerae are the common agents, whereas dysenteric diarrhea may be due to Clostridium difficile, Salmonella, Shigella, enterohemorrhagic E. coli, Yersinia, amoebiasis, and giardiasis. The clinical feature we all know: nausea, vomiting, diarrhea, anorexia, abdominal pain, abdominal cramps, melena, giddiness, etc. The investigations: total count, differential count, renal function test, serum electrolytes, stool culture, and Clostridium difficile antigen, and ova cyst for amoeba and giardiasis. Treatment: rehydration, avoid antimotility agents, probiotics can be used, and antibiotics in selected cases. Important indications: the most important thing is the indications for antibiotic in acute gastroenteritis. We can use antibiotics only in the following cases: if the symptoms last for more than 72 hours, if the gastroenteritis is associated with fever, when there is bloody stools, when the infection is hospital acquired, or when there is traveler's diarrhea. What antibiotics can be used? Once again, azithromycin 1 gram per oral for 3 days, or ciprofloxacin 500 milligram BD for 3 days. These two for bacillary diarrhea and dysentery, and Septrin, that is Bactrim double strength, 3 days for traveler's diarrhea. Metronidazole 400 milligram 3 times daily, 7 days, or tinidazole 2 grams for 3 days for amoebic dysentery. Probiotics. Probiotics are very useful in the management of dysentery and diarrhea. They enhance the mucosal immunity, they enrich the bacterial flora, and prevents antibiotic-induced floral depletion, and inhibits pathogen-induced cell signaling. The last topic is hepatitis A, jaundice. Hepatitis A, formerly known as infectious hepatitis or epidemic jaundice, is an acute infectious disease caused by hepatitis A virus. Hepatitis A virus, the jaundice the more the age, more will be jaundice as a manifestation. That is, if for children, only 10% they will present as with jaundice, and above 14 years, about 70 to 80% of the people will present with jaundice. And this hepatitis A will present with 3 different clinical syndromes. One is a fulminant hepatitis, that is sudden severe onset hepatitis with painful abdomen, pain abdomen. Cholestatic jaundice, that is liver inflammation due to arrested bile excretion and relapsing hepatitis. Chronic, there is no chronic sequelae for hepatitis A infection, and once you get an infection and when it gets cured, there will be a lifetime immunity for you. The symptoms: jaundice, pale color stools, dark urine, malaise, anorexia, nausea and vomiting, abdominal pain, headache, myalgia, skin rashes, pruritus, arthralgia, arthritis, and fever. And the diagnosis of acute hepatitis A is made by detection of anti-HAV IgM in serum. This anti-HAV IgM indicates an acute infection, whereas an anti-HAV IgG indicates a previous infection or old infection. And this IgM will appear around 3 weeks after the exposure, and there will be an increase in the titer. Apart from hepatitis A, HIV, IgM, there will be an abnormality in the liver function test, which shows an increase in the bilirubin, AST, ALT, and alkaline phosphatase, an increase in prothrombin and APTT, and there is a decrease in the total protein albumin ratio. This is the picture of how the antibody response will be. The IgM response will occur between 3 to 8 weeks, and gradually it will fall, whereas the IgG will start increase only after the fall of IgM. That is, after 8 weeks only, you will get a significant titer of IgG. And management, there is no drug therapy for treatment of acute hepatitis A. Rest according to patient level of fatigue, hospitalization, and supportive care. That is, care of nutrition, care of the patient with IV fluids, and paracetamol. You can give up to 3 grams of paracetamol even at jaundice. So you can give paracetamol and tepid sponging for fever, and you could take care of the electrolytes and fluids. Small frequent feeds with high calorie and low fat diet. Proteins may be restricted. Nominal protein restriction can be done, and high carbohydrate diet are preferred. Vitamin K injection if the prothrombin time is prolonged, and IV fluids and electrolyte replacement and antiemetic drugs can be given. And there are some studies which says that the drugs we commonly used in the outpatient setup, like Lev-52, all those medications, increases the duration of bacteremia and other complications like fibrosis and all.
Vitamin prothrombin time prolonged vitamin D.
And the hepatitis A vaccine, for children, there are 2 doses should be given for children, whereas above 18 years for adults and for elderly patients, you can give only 1 single dose is enough, because the antigenicity will be good and better in for adults, and the antigenicity will not be good for children, so they need a booster dose at when they are less than 18 years. Thank you.
Thank you, Dr. Ravishankar. Ravishankar, you can exit the screen.
Yes, sir.
Screen share on the exit pannirunga.
Yes, sir.
Please exit. Exit your screen share. Thank you.
Thank you, sir.
Sendil?
Yes, sir.
Yes, Sendil.
So now we will have our felicitation talk by our immediate past national president, sir. Just a few minutes, sir. Meanwhile, you can get with your slides.
Sir. Yes, sir.
இல்ல சார் அதெல்லாம் முடிஞ்சது உங்களே மியூட் பண்ணு
Sendil? Jayalal sir irukara? Sendil? Abul sir? Karthik Prabhu sir? Sandamil Pari sir?
Yes, sir. Sir, they are not online, sir. You can start the session, sir.
Yeah. Am I audible? Is my slides visible?
Yes, visible.
Sendil, am I audible?
You are audible.
Yes, sir, you're audible, sir. You're audible.
slides are visible?
Yes, the slides are
Friends,
visible, sir. You can, sir.
Yeah.
Yes, sir.
Yeah, friends, today we'll be talking on evidence-based management of the current fever scenarios, particularly monsoon illnesses. We are dealing with post-flood situation. So I'll be talking on dengue, flu, lepto, and COVID JN.1. So friends, let me go rapidly to the slides. So the objective is to have an interactive seminar with evidence-based answers. I request everyone to mute yourself. I request
പായിട്ട്
Friends, now we have a bucket full of viruses that is happening in our society, particularly down south in our state. You have lots of flu, you got dengue, you got leptovirus, leptospirosis, you got in some areas of Kerala, Karnataka, you got COVID JN.1, rhino, H1N1, H3N2, all sorts of viruses, bacteria, spirochetes, everything is there in the society. That's because of a phenomenon called immune lacunae following the COVID. So let's quickly go into the 4 common diseases that we see. First of all, you must know that fever per se is not a disease. It is a manifestation of underlying disease. Fever is a friend. Do not chase the fever. Do not give medicines one after another to reduce the fever. On the first slide itself, I like to stress that you should use only paracetamol. Do not use any other drug other than paracetamol, particularly during this monsoon period. The most important message. Okay, here you have a 7-year-old child who develops a high-grade fever with severe sore throat, dry hacking cough. The commonest question is it viral or bacterial? Please remember, if you start applying this 5-point rule for every child whom you see in your day-to-day practice, you can take a picture of this, or at the end of the meeting, you can send a request to my cell phone number, which will be projected in the thank you slide. I'll send you the slides. Just apply this 5-point rule for every child whom you see, and invariably, vast majority, more than 90% of the children will be viral in nature. They do not require any antibiotics. They require only paracetamol and ORS. The only thing you need to tell them is about the danger signs counseling. So they want education, not the material, not the medicines. Having made a diagnosis viral fever, you briefly divide them into respiratory and non-respiratory. Respiratory is flu, non-respiratory is dengue. So if a child comes with high-grade fever, sore throat, dry hacking cough, probably it is influenza-like illness caused by these 7 viruses. It is one among them, and influenza is one of them. And most of the time, this influenza-like illness in young children, it is mainly of high-grade fever. Usually, they have abdominal symptoms like diarrhea and vomiting, nausea. So they are called as gastric flu. Whereas in adults, the cough is a more presenting feature. Whereas in elderly, it's more of a rhinitis and nasal symptoms in elderly. So flu behaves differently at various age groups. So we have A, B, C of flu. And the C we don't see in our clinical practice. A is the one that causes pandemic, Russian flu, swine flu. B causes sporadic illnesses. So you categorize flu, and based on this category, you treat them. A mild category is called, a mild illness is called category A, which accounts for 91%, and a moderate accounts for 8%, and severe usually you see in less than 1% of the children who have flu. So coming to mild form category A, we do not do any tests, no oseltamivir, just home isolation. Give paracetamol, give ORS, no aspirin because of Ray's syndrome, no antibiotics, no steroids, no IM injection. Very, very important. Many times if they come to you with high fever, suppose if your time is bad and if you give IM injection, fever comes down. Sometimes rarely a child in incubation period of polio can develop a provocative polio. All of your practice will be gone. Never try to satisfy patients by giving IM injection. That's another important message. So always give a counseling about warning signs. They have to come back to you even if there is fever, the child is sick. That's a very, very important that you have to write. If there is a warning sign, they have to come back. You have to write in your prescription. If the child has got chronic disease of the organs, or the child is less than 2 years of age, and child has got obesity, BMI more than 40, or asthma, COPD, or diabetes, or immunosuppressive drugs or disease, and adults more than 65 years and pregnant mothers, all these 10 conditions accounts for comorbid condition. If they have a flu, and if it is mild in nature, but if they got comorbidities, automatically they become category B. You have to start on oseltamivir without doing test. It is based on your clinical judgment. Right? Category B influenza and start on oseltamivir. And never misuse oseltamivir for mild influenza. And even these children do not require any RT-PCR, or they do not require admission. They do not require antibiotics. And if a child has got tachypnea, tachycardia with hypoxemia, hypotension, cyanosis, shock, drowsiness, seizures, and dehydration, immediately that child is considered as category C. The child has to be referred as early as possible. In our hospital, we admit the child, isolate the child. We do testing on one hand, RT-PCR. We start treatment oseltamivir on the other hand, both at the same time. We do not wait for the lab report. And we also intimate the health authorities. Sometimes, if you think the child can have had a recent history of travel to Kerala in endemic area, you need to take along with that, you have to take a COVID test also. You have to inform the health authorities. So many of these children with category C, they go in for severe pulmonary pneumonia, ARDS, and you need to start on broad spectrum antibiotic after taking culture, ceftriaxone. So please remember, in flu, most of the time the WBC count is normal, neutrophils is normal. X-ray shows bilateral symmetrical infiltrates mimicking ARDS. In severe cases, you have elevated LDH, and the mortality is very high in a severe case, category C. So you need to start oseltamivir as early as possible. So the message is, earlier the better. If you start oseltamivir within 48 to 72 hours, the symptoms are melt down immediately, rapidly. So the dosage of oseltamivir is very simple. In children less than 1 year of age, it's based on months of age. It should not be given for neonates. For children more than 1 year of age, it's based on the weight. And the maximum dose for child more than 40 kilos is 75 milligram. If you want to treat, you have to give 75 milligram BD for 5 days, even for adults. And if you want to give chemoprophylaxis for the contacts, you need to give 75 milligram OD for 10 days. That's for adults and older children. And the other antivirals are zanamivir, which is an inhaled drug given over 7 years of age. And that is an IV route, which is used in ICUs called perimivir. And a newer drug is called baloxavir, which is given over 12 years of age. So the commonest question is, when do you start an antibiotic in a child with flu? Not only flu, in other viral illnesses. Only 3 indications. One is recrudescence of fever. Normally, in flu, fever settles down by 2 to 4 days. If the fever persists beyond 5th day, you can start on antibiotics. Second is prolonged fever. If there is a recrudescence, fever disappeared and reappeared, or a fever beyond 5 days, or a deterioration in clinical conditions. Only in these 3 conditions you are allowed to start on antibiotic. There is no role for prophylactic antibiotic for all viral fevers. Please remember, many children, vast majority of the children, do not develop bacterial illness following viral illnesses. So if they are immunocompetent, they never develop secondary bacterial infection. So the difference between common cold and flu is that flu is a severe form with more of a high-grade fever and a severe sore throat and a dry hacking cough, less of sneezing. Whereas in common cold, it's more of a nosy, stuffy nose than the other symptoms. If you don't treat the flu, in vast majority, more than 90%, they will settle without treatment. So masterly inactivity. There is a rule called rule of 2. The incubation period in influenza is 2 days, 2 hours to 2 days. Fever lasts for 2 to 4 days, and the cough lasts for 2 to 4 weeks, and asthenia lasts for tiredness. Asthenia lasts for 2 months in a severe case of flu. That's called rule of 2. You have both pulmonary and extrapulmonary. In very severe sick cases, particularly in ICU, we got shock and multi-organ dysfunction with renal and coagulopathy. We have seen children with myocarditis and encephalitis. Whereas in your OP practice, day-to-day illness, secondary bacterial infection is rare. In severe cases where you don't anticipate and give third-generation antibiotics in a child with ICU category C, many of them develop primary viral pneumonia or secondary bacterial pneumonia. So there are vaccines available to protect the present strains. There are Southern Hemisphere vaccine which comes to India by around March, and Northern Hemisphere vaccine that comes to India by around August. The live vaccines is the one that is given as a nasal spray above the age of 2 years, contraindicated in pregnancy. Now we don't have that vaccine. The vaccine available now is an intramuscular injection called inactivated influenza vaccine given above the age of 6 months. It's safe in pregnancy. You need to give for children above 6 months of age up to adults. The dose is uniform irrespective of age and weight. It is 0.5 ml IM. When a child below 8 years of age, when you're giving for the first time, you have to give 2 doses with 4 weeks gap. For older children, it's enough more than 8 years if you give only 1 dose. And every year you need to give a filler dose. I'll tell you later. This is the present strain that is available, 23-24 strain. An annual revaccination is mandatory because there is a small antigenic drift, small changes in the envelope of the virus. You need to change the vaccine every year. So in those who receive vaccine should take annual vaccine. Even with patients with egg-allergy, you can give the vaccine, but you have to keep it with caution. You need to have adrenaline, oxygen, hydrocortisone, and other emergency medicines on table and then start it. And flu vaccine can be given with any other vaccine. This is the indication. You can take a picture, or end of the meeting, you can send me a request to my cell number. I'll send you all the slides of 4 diseases. The priority is given to children above the age of 6 months to children below 59 months of age, and adults more than 15 years of age, those who have chronic disease of the heart, lung, brain, kidney, liver, and those who are immunosuppressed, and mothers who are in pregnancy during influenza season carry a high risk, more than 33% risk. So they should be given a priority. And the most important message in this slide is all the doctors who attend this CME should take influenza vaccine today or tomorrow. So this is the timing of vaccination. If you see in Kerala and South, Nagarkoil, Kanyakumari, places like Coimbatore bordering Kerala, where we get monsoon early, we can take the vaccine, Southern Hemisphere vaccine in May. In other places, Chennai and North India, you need to take the vaccine between July to September, where we get the monsoon. So let me come to the important prevention message, both for doctors and public. For children, you have to educate them about cough etiquette, and you need to avoid handshakes, and please follow a technique called hands off face for the next 3 months. I request all the doctors who are in OP or an IP not to take your hands during OP or IP anywhere to the face, eye, nose or mouth, because your hands act as a carrier. And the best cheap and preventable strategy is to wear a mask, particularly now that we know lots of viral illnesses. In OPD, you can wear a now simple surgical mask. When you are in ICU, PICU or ICU, you need to wear N95 mask. So carry home message is very simple. Vast majority category A, no test, no treatment, no oseltamivir. In rest of the category B, where they have got comorbid conditions, you can give oseltamivir without testing based on your clinical judgment. In less than 1% who has a severe disease, you need to refer, and you have to do all these 4 at the same time. For pediatricians, you take a nasopharyngeal flu swab for flu, RSV, human metapneumovirus, and COVID, not for other viruses. In bacteria, you can do it for pertussis. Whereas throat swab is not a good test for LRI pneumonia. It will give you common salts in the throat. So always educate the public to use pulse oximetry. They have to come back to you with the oxygen saturation is less than 95. Let's go quickly to dengue. We have a 3D approach: do's, don'ts, and definite. So I'm going to tell you what are the do's that you need to do, what are the don'ts you need to do. If you look at the pattern of the disease, dengue is basically a 11-day illness. This is a simple slide. Take a picture of this. This will show you how the dengue will behave. The first 3 days, the fever will be there, parents will be concerned, hemodynamically child will be stable. The maximum thing is they can go in for dehydration. Give only paracetamol, preferably don't give beyond 15 milligram per kg per dose, not exceeding 80 milligram per kg per day. Only co-prescription is ORS. You have to tell them young child 50 ml per hour, older child 100 ml per hour. You have to educate them about danger signs and do not do any CBC on day 1 of fever. The complications arises after the disappearance of fever. Tell every child's parents that even if the fever disappears, should the child become dull, should the child develop danger signs, which in my slides, next slide I will show you, they have to come back to you. Because during the day 3 to day 6, they develop shock and bleeding or organ impairment. The first thing you see in a CBC is hematocrit. There will be hemoconcentration. Please remember, dengue is not a platelet disease. Do not treat the platelet. You have to treat the patient. So you have to treat the child if the child has got danger signs. So that's very, very important. So whenever you make a diagnosis of dengue, you have to be very, very careful when you are prescribing antibiotics. Do not use anything other than paracetamol, because your NSAIDs like ibuprofen, mefenamic acid, can cause thrombocythemia and the child can bleed to death. And never give IM injection. Never treat them as outpatient by giving BD IV fluids. Always, dengue is a dynamic disease. Educate them. A child who appear in the normal in the morning can become very severe in the afternoon. So it's a dynamic disease. And never give antibiotics for a child with dengue. Never use steroids. Never give IM injections. And having seen this, as I told you, a simple dengue can become severe dengue in a matter of hours. So you need to have a watchful eye. You have to educate every patient. Suppose if you are able to pick up a child with warning sign, admit the child, start on normal saline, the mortality in your hospital will be 0. If you fail to recognize a warning sign, the mortality will be 25%. So we need to make our state, our country, dengue mortality-free state or country just by education. If there is a abdominal pain or a right-sided tenderness, or there is a persistent vomiting or a reduced urination, or there is a sign of fluid accumulation or a mucosal bleed, if there is excessive lethargy or restlessness or irritability with the increasing hematocrit, these are the signs that the child needs hospitalization. These are called danger signs. At the end of the meeting, I'll send you the slides. Please send a request to me. So the most important message is education to the public. They need to come back even after the divergence of fever if there is a danger sign. And never send them home with IV fluids that is given morning and evening, because there is a continuous leak from the intravascular compartment. If you keep on giving fluids in the morning and once in the evening, the compartment syndrome will be developed, child will develop iatrogenic pulmonary edema, mortality will be high. You need to give fluids at a calculated WHO recommended dose, 24 hours. Okay. And you need to monitor the child both clinically and hematologically. So I request all the doctors during this dengue season to do a simple test called Tourniquet test. At the end of the question answer session, if you ask me this test, I'll tell you how to do it. Whenever you do test for first 3 days, you can do NS1 antigen. NS1 is non-structural glycoprotein that is seen during the period of viremia. It means that our child has got viremia. It doesn't tell you about the severity of the illness. As I told you, vast majority of the dengue or simple dengue, primary dengue, the virus will be there, the child will not have any disease. So you need to follow periodically, the two during the period of defervescence. And do not do CORD test because of high false positivity, high false negativity. From today onwards, focus on patient, not on the platelet. Dengue is not a platelet disease. You can have a very sick child with a normal platelet count. and you can have a normal child with a low platelet count. So always do IgM and IgG by ELISA method after 5th day. And your treatment has to be based on the clinical parameters, not based on your lab parameters. And during the febrile period, try to give paracetamol at a lower dose. Normal dose is 15 milligram per kg. Please give 10 milligram per kg, particularly when you suspect dengue, because dengue is a hepatotropic virus. And always never encourage commercial carbonated drinks, because some of the parents will tell that instead of ORS, can I give that and this? This contains hyperosmolar solution that will cause cerebral edema. And do not chase the fever. You have to make a clinical empirical diagnosis and treat the cause of fever, not the fever. And this is a simple management protocol you need to follow in your practice. Always use normal saline. Before you put a Venflon, take a hematocrit. And the fluid is 10 ml per kg per hour, given slowly over 1 hour. At the end of 1 hour, repeat a hematocrit and see whether it is normalizing. If the capillary refill time is better, improving, child started passing urine, abdominal pain disappears, appetite reappears, then the child, it means child is improving. You can gradually taper the fluids from 10 ml to 7 ml per kg, given over 2 hours, then 5 ml per kg next 2 hours, then 3 ml, then 1 ml. Over a period of 24 to 48 hours, you can stop IV fluids. Maximum the fluid leak, capillary leak happens for 48 to 72 hours. Do not give more fluids beyond 72 hours. You will end up in iatrogenic pulmonary edema. On the other hand, if the child doesn't respond to first bolus, you can give a second bolus of 10 ml per kg weight normal saline. Even with second bolus, the child doesn't improve. That's a candidate for referring to a center where PAC is there. If there is a hematocrit fall below 20%, you need to think of occult bleeding. You have to start on packed RBC 10 ml per kg per hour, 10 ml per kg. If there is a sudden increase in the hematocrit more than 20%, he is a candidate that shows that there is a leaks, there is a severe hemo concentration. He is a candidate for colloid in spite of 2 boluses. So please remember, you need to monitor 5 important things. They are: number 1, you need to monitor clinically the urine output, because urine output is called poor man's CVP. It is not influenced by CIRS. And always monitor the hematocrit. In the ward, you have to monitor hematocrit twice a day. Do not monitor platelet. See the difference between systolic and diastolic. That's called pulse pressure. And do not rely upon SpO2, because sometimes even a child with shock in dengue can have a normal SpO2. Sensorium also can be normal. And always look at 5 important parameters. 1 is urine output, 2nd is pulse pressure, 3rd is hematocrit, 4th is heart rate, and 5th is respiratory rate. If there is a sudden increase in the heart rate, you better refer the child to somewhere, because before hypotension you have to refer. There is a sudden increase in the respiratory rate, probably child has gone into recovery phase, child is developing pulmonary edema, compartment syndrome, stop IV fluids. There is no role for prophylactic platelets. That's a very, very important message. Never give prophylactic platelets. In dengue, bleeding is not because of thrombocytopenia. It's because of there are 12 other factors other than thrombocytopenia. IV fluids has got narrow therapeutic index. Do not start IV fluids during the febrile phase when the child is clinically normal. And do not give IV fluids beyond 48 to 72 hours when the child has come to recovery phase. And always monitor inpatient carefully, because a simple dengue can become severe dengue in matter of hours. From today, forget platelets, focus on patients. And refer is not based on platelet count, it's based on clinical condition. If the child from febrile phase, simple dengue, if the child goes into leaky phase or a critical phase, develop danger signs, immediately refer even with a normal platelet count. Please remember, it is the disease that causes fever that kills the child, not the fever. Do not chase for the fever. Always, I request everyone to do triage. It takes less than 30 seconds. Educate your receptionist to do this. Only it's what we do is called CCTVR. Look at the patient's pulse volume, capillary refill time, color of the baby, temperature of the extremities. When the body is hot and the peripheries are cold, he is a candidate to be referred. So the outcome is time and knowledge sensitive. If you are knowledgeable, if you practice triage for all the children, you will have 100% successful practice. With that, let me go to the last but least, leptospirosis. Friends, following these floods, there may be lots of contamination with the urine of rats. There is a chance that people in and around floody areas can develop this zoonotic disease. So please remember, it's caused by a spirochete called Leptospira intragans. Most of the time, the reservoirs are rat and mice, and sometimes it comes through infected urine comes to human also. It's highly susceptible to heat and chlorine. So during monsoon time, you have to request every patient to boil the water and drink, and the government should chlorinate the water. So please remember, the immunity in leptospirosis, you can get it second time because there are multiple serovars. That's why you don't have a vaccine also. As I told you, human is an accidental infection that can be prevented. So the incubation period is around 7 days. So particularly after floods, after 2 weeks, you will be getting leptospirosis. You will get flu immediately during rains, and after a few days you will get dengue. After a few weeks you will develop leptospirosis. These three things you have to keep in the back of the mind. So basically it is a vasculitis disease. It is also biphasic disease. There will be fever, absence of fever. There will be another fever. During the second fever, like dengue, many of the biphasic disease, dengue, strep typhus, and leptospirosis, the mortality happens during the second spike. So when there is a lung involvement, there is a poor prognosis. The mortality is 5%. The main symptoms which the patient come to you is fever with chills, with headache, with sweating. Sometimes there will be eyes, both eyes will be conjunctiva, will be suffused. So in a season like this, if you have a child with conjunctival suffusion, with myalgia, headache, and fever, think of leptospirosis. Particularly, you have to take a history whether they have visited the fields. Vast majority are anetric fever, only minority becomes icteric or wheel space. So in majority of the 90% of leptospirosis, mild fever, myalgia, no jaundice, self-limiting, you need not treat them. Only some of them will develop complications. So mainly, the myalgia is in the calf muscles, abdominal muscles. If we do a serum CPK, creatinine phosphokinase is elevated. So that means probably you're dealing with a child with indirect evidence that the child has got conjunctival suffusion with muscle pain, fever. It's probably child has got leptospirosis. In such a situations, even before testing, you can empirically give azithromycin for children. So as I told you, Weil's disease, which is a icteric form, is very, very rare, particularly in young children. It's a disease of young adults more than 30 years of age. It's not a disease of children, where the mortality rate is high in more than 30 years of age. So many a times you have polymorphic leukocytosis with elevated ESR. The most important thing is elevated CPK with thrombocytopenia. The gold standard is to do a MAT, microscopic agglutination test, wherein the report shows more than 800 units, which is positive. The sensitivity and specificity is very good. So you can do a leptospira agglutinin test when there is a 4-fold rise in confirmation. Sometimes in our institution, when we have a sick child, we do RT-PCR. So differential diagnosis was, because please remember, 3 sisters. One is dengue, another is leptospirosis, another is strep typhus. All are called sisters. They come together. Sometimes you can have malaria and influenza mimicking them. So the treatment ideally as per textbook is penicillin G. In our practice, in older children more than 8 years of age, you can use doxycycline for a period of 4 mg per kg weight per day for a period of 7 days. In older children more than 8 years of age, azithromycin 10 mg per kg weight on day 1 and 5 mg per kg weight rest of the days for a period of 5 to 7 days in children less than 8 years of age. So please remember, when you have a doubt on when there is a history, when there is a setting with conjunctival suffusion, you can start on empirical azithromycin. Particularly when there is a setting, do not misuse antibiotics. So Let me come to the last one. That's called COVID-JN.1. It is common now. You have seen lots of cases, spurts of cases for the past 3 weeks in Kerala, Karnataka, Maharashtra, and Jharkhand. Now the government is doing an intense scientific scrutiny, and please remember, it is not a cause of concern. As per WHO, it is defined as a separate variant of interest. That means, because of the fast replication, high transmission, it has an immune escape mechanism. That's why we are a little worried. The transmission rate is very high. But fortunately, vast majority of them symptoms are mild. Some of them with comorbidities can have a high-grade fever with a severe headache and body pain. And the mortality is high only in comorbid conditions. In normal immunocompetent persons, the mortality is very low. What is the implication for the public? As of now, we don't have lockdown. There is no expectation for lockdown for this JN.1. The current vaccines continue to protect against JN.1. And the recommendation for doctors who are attending this meeting, you should wear a mask, simple surgical mask in your OP. Those in ICUs wear N95 mask. And next important recommendation is to take influenza vaccine. With that, let me come to the last slide. Just by doing a CBC, you can tell whether it is dengue. If the hematocrit is high, probably it's dealing with dengue. If there is a leukopenia, do not look at the platelet count. The thrombocytopenia is dengue is because of a mechanism called molecular mimicry. The antibodies that are produced on day 3, IgM antibodies, they are supposed to destroy the viruses. But unfortunately, since the virus and the platelets have got molecular mimicry pattern, instead of destroying the virus, our own antibodies destroy our own platelets. It's nothing but an ITP. If there is a thrombocytopenia, it means your body is producing adequate amounts of IgM antibodies. So when you have a high hematocrit, probably dengue. When you have eosinopenia, you have enteric fever. When there is a monocytosis or eosinophilia, you have malaria. So with these three, just by looking at CBC, you can tell whether it is malaria or enteric or dengue. So I said 91% of your practice, you need not give antibiotics. Less than 9% of the practice, you need to give antibiotics. You have to use only 3 antibiotics in pediatric practice. For supradiaphragmatic infection, it is gram-positive infection, it is amoxicillin. Infradiaphragmatic gram-negative infection, it is cefixime. And skin and soft tissue antibiotics is cefalexin. Please, those who want the slides, please contact me through 984221179. So you can send a request to me by WhatsApp. I'll send you the slides.
Sir, thank you, sir. Sir, now
Thank you, sir.
can we have our immediate past national president, Dr. Jailal sir, and Dr. Sengutun sir, to give his felicitations and address, sir.
We are very happy to invite Dr. Jailal sir and Sengutun sir, who are national leaders, to give felicitations, sir. And
sir, Sengutun sir.
Yes.
So I request Dr. Sengutun sir, our President-elect IMA TNSP, to give his address.
Right. Thank you for the opportunity given. Thank you for the opportunity given by the Director of CGP, Dr. Sendil, respected President of the IMA, Honorary Secretary, World Medical Association, Dr. Jay Jailal, and IMA officials, Honorary Secretary, and Finance Secretary, and other participants. Let me thank you for the opportunity given. As usual, Dr. Neminathan has explained everything in detail during this monsoon illness period, what to do and not to do. I thank Dr. Neminathan for his continuous effort to educate the doctors group for this current period. I also thank Dr. Ravi Shankar for his detailed lecture about the typhoid fever. I thank all the officials of the IMA wing of the CGP group. Thanks for the opportunities given. Thank you. Thank you, Dr. Neminathan.
Thank you, sir. Thank you so much, sir.
Thank you, sir. Sir, sir is not able to join. Once he is coming, we will have his address, sir. So we can start the next session, sir. And we have the Q&A session at the end.
Yeah, we are happy to invite Dr. Suresh Kumar, who is a fellow of infectious disease. He is a consultant, senior consultant at Apollo Hospital, Chennai. He is an American certified tropical medicine specialist. He is a co-founder of Best of IDs. So I would say he is one of the persons who immediately say yes whenever we have an educational program. The moment immediately I asked him a couple of days earlier, immediately he said yes. So far, we have conducted many number of meetings along with him, and he is going to be part of the infectious disease certificate course of IMA CGP. So he is a very, very academically shrewd and also always ever willing to share his knowledge with the doctors in our country. Welcome, Dr. Suresh Kumar.
Thank you, sir. Thanks for the kind words of introductions. Before that, am I audible?
Yes, sir. Your audible slides are visible, sir.
Thank you, sir. Thank you. I first sincerely thank the IMA CGP for giving this wonderful opportunity and Professor Dr. Neminathan sir for giving this opportunity and kind words of introductions. Since we are running a lot of short, so I'll make my presentation little crisp also there. So before that disclosures, this is Naga Ham Chennai Karan. People call 10 days back or 15 days back, this has happened to us. In fact, I reached my hospital via the boat. After a certain limit, I can't go behind my car. So I stop my car and go by boat to reach my hospitals. And this is what they used to call how Tamilians can build the home, but it's suitable for Chennai people there. They build the houses in the areas of lakes and rivers, and we are suffering. And people are asking how December is going on. This is how December is going on for so many people there. Okay. So straight away I begin with the case here. My family was walking.
Sir, sir, can you have your slides, sir?
Can you? My slides is not visible, sir.
It's not visible, sir.
1 second, sir. Now, sir.
Yes, it is visible.
It's visible, sir.
Okay.
Fine, sir. Okay. Yes.
Okay. So my family was walking in the flood water for 2 weeks back.
Sir, sorry for the interruption, sir. We have our past president, Dr. Jailal sir, on the line now. Can we spare a few minutes, sir?
Sure, sir. Sure.
Yes, sir. Sir, I request Dr. Jailal sir to give us the keynote address. There is the Secretary General of Commonwealth Medical Association as well. So kindly proceed, sir. Sorry for the delay, sir.
Yeah, no problem. No. And I'm so happy that IMA CGP is organizing this program. It is a very important thing which we are doing at this moment, because as we are seeing, there is the cases of COVID and respiratory illness are increasing in our country. So this is a objective of Indian Medical Association College of GP, that at the right time we are giving the inputs, what is necessary for the doctor community to follow, what is necessary the doctor community to observe in the country. Today is a very important day for our Indian Medical Association is concerned. It's a long since we were fighting for establishing the sanctity of the medical profession. But unfortunately, with the introduction of the Consumer Protection Act and other subsequent law, which has become criminalization of the medical fraternity, whatever is done in a good faith, whatever the good help we are doing for the society is also discriminated or criminalized, and unnecessarily we are dragged to the court and the police station. We know the death of the Archana from the Rajasthan just because the 304A was filed and she had to commit the suicide. So it is ever since then that Indian Medical Association is fighting hard with the government of India to make sure the doctor profession or medical negligence is not brought under the criminalization. Thanks to government of India, at the process of their amending the IPC and other act, they have willfully, with their wisdom, so introduced an amendment which says that medical negligence cannot be criminalized. So that means that 304A cannot be applied to any doctor whenever something untoward events are happening in place. But at the same time, this is only a protection which is given legally. But other sections like Code of Ethics, our ethics, autonomy, and the do no harm, all that principles that we need to adhere to that. So at that juncture only, like whenever the association is also involved in disseminating the knowledge and skill to the epidemic diseases or the common diseases which are affecting the people. We are now today in a world, now country is slowly facing towards the COVID fresh endemic episodes, which started in America. Now Singapore still having a large incidence. There's nearly 56,000 people are involved in per week in Singapore. But last few days in India also, we are seeing the increase in the case. But fortunately, we are all confident that this case is the incidence is, the number is though increasing. The problem or the complications of the disease are comparatively low. So though the government has put all the alert and all the vigilance across the country, and we are also prepared to face, but what the general practitioners and as the IMA Mumbai, we are advising the people to have a suspicion of this, because many people coming with a fever and sore throat, we should not presume it is only influenza, and we should be able to have a conscious attention towards that and early identification of the disease. Though out of 2,000, 3,000 cases reported, only 21 cases of JN1 virus has been identified, but there may be a little more incidents. So not only like this COVID and all the epidemiological disease, all the concerned problems, IMA College of GP is doing a human job. And I must especially thank Dr. Sendil and the team of office bearers associated with the IMA CGP because of their exemplary work in organizing such a meeting. I'm so happy to see that in almost all the programs which is organized by Sendil, more than 500,000 people are joining and they are benefiting. I always firmly believe that once the doctor, the knowledge and skill is given, it will not be confined to the doctor. It will be definitely percolate to the society, and ultimate beneficiary of the society, ultimate beneficiary of the common man. So that is a dream of IMA. That is a dream of IMA College of General Practitioners, that by giving knowledge and we are giving service to the society, we are service to the community. So on that ground, I appreciate IMA CGP for that human job you are doing. Thank you very much, Sendil, for that exemplary work. Continue to do this job. I think you have a larger role to play in this IMA College of General Practitioners in the days to come. I wish you all the best and wish all the office bearers of IMA all the best. Especially this year is going to be a golden year for IMA Tamil Nadu with a very dedicated, dynamic president, secretary, and office bearers up there, and you will all be able to do a better job. So thank you very much for this opportunity. I wish all the best for the program to continue.
Thank you, sir. Thank you very much for your update on the current proceedings as well. Thank you, sir.
Thank you.
Okay.
Dr. Suresh, kindly proceed.
Sure. So this was happened to the people for the last couple of days back and still happening in southern part of Tamil Nadu. My family was walking in the flood water. What can I get now? Diarrhea, malaria, dengue. I think previous speaker has covered a lot of things like leptospirosis, and other previous speaker covered typhoid and jaundice. Flu also covered. So I'm going to cover what remaining things I'm going to cover in my talk. So why floods and infections we are talking today? Basics of flood and infections, common skin infections, what we are seeing during the time of flood, other infections, and what is new after floods, summary and way forward. This is not only happening to the Chennai, this is not only happening to the southern part of Tamil Nadu. Floods is going to happen in any part of the world. It's not going to subside, it's not going to settle with one floods. So basic learnings of floods is essential for any practicing doctor. That's what I'm going to discuss in next couple of minutes, my slides there. Why floods? If you see, this is a Lancet article. Unfortunately, sorry, it was hidden there. Lancet article said climate changes can affect anything. Particularly, the most important climate change is the floods. If you see, compared to the other things, cyclone or flooding or severe storm, whatever things, flood affects more populations compared to any other thing. That's what we have seen. People who experience, whether it's Chennai or whether it's a southern part of Tamil Nadu, people are experiencing what is the impact of the floods they're causing there. Even doctors also suffered. And floods, if you see, compared to any other diseases, it causes more infections. Compared to any other diseases, it causes more infections and associations. It's not 1 year or 2 years. This is happening periodically. The numbers is keep growing compared to what happened in the past. Number of flood-related events and flood-related infections numbers is keep growing. The health risk, if you see the health risk, definitely going up. Among the health risks, what I'm talking about, whether it's early following the floods or late following the floods, skin infections and soft tissue infections plays a big role. And this is not happening in India alone, this is happening across the world. That's why I'm telling flood affects most of the populations. It brings a lot of infectious diseases. Among the infectious diseases, most of the infectious diseases My colleagues has already answered. I'm going to talk about skin and soft tissue and other infections I'm going to develop in next 20 minutes there. So why this topic? If you see the decade after decade, the flux number is keep growing. Decade numbers is going up. And these are all the waterborne organisms. When we expose to the water, what are all the organisms I'm going to get? And what is the route of exposures? Either drinking the contaminated water, or exposed to the bare skin, or exposed with some traumatized skin, or because of the injury what we have sustained, so we are going to expose. So I'll come back and explain what is the timeline also. If we see, depending upon the incident, depending upon the timeline, lot of infections. If you search for it, most of the time we can find out mostly it is leptospirosis is more common because lot urine mixed with the water and we are working through the water and wading through the water. Second thing, gastroenteritis is more common, either typhoid or cholera or some viral diseases. But in fact, people are walking in the rainwater for longer durations. They are getting also fungal infections is possible. So this is a durations. If you see 1974, mostly is schistosomiasis, but fortunately, the vector of the larva is not available in India, so we are not getting the schistosomiasis, but we are getting amoebiasis, salmonella, and giardia. Then always, if you see lepto, then comes dengue. Then after 2011 onwards, we start seeing that dengue is more common, leptospirosis. I'll show what is common in after 2015. I'll also show some data what we are seeing in 2015 onwards. So floods are increasing in number. Flood-related infections also increasing in the number. So you need to prepare for your practice. What are all the events you are going to prepare in the future of the floods? We keep in mind that's most important thing. So not only the floods are increasing, not only the flood-related infections are increasing, death due to flooding. Previously, people die not because of the infections, because of some electrocution. People are stepping into the wire, or people fall in some dump. This also happened in this time. Chennai, what happened in Velachery area? The ground fell down and a lot of people fell during the event and died also there. That's not because of the flood, because of the mechanical causes we can call. But flood can cause infections and death, yes. Particularly people getting a gastrointestinal infections like Vibrio cholerae or some of the viruses called Rota or Norwalk viruses, they can get severe form of gastroenteritis and die. Leptospirosis, my previous speaker alluded, previously Weil's disease is common, that is a killer. But nowadays, early recognitions, thanks to IMA CGP type of forums, they educate the clinicians, the pickup rate of leptospirosis and other killer diseases little early. So people survive much better. So that's the reason for leptospirosis number is going down. But other diseases, I'll show in a minute later, that is killing the people. So floods not only is common during these years, the flood-related infection is going up and flood-related death is also happening. That is why we are discussing why flood is more important for a practicing clinicians, how to approach flood is more important. Usually we divide the flood into 3 phases. One is called the acute phase. During the flood, for example, 0 to 7 days is called the acute flood while you are walking in the rainwater or the flood water is invaded your house. What are all the infections you are going to get? Usually this is more of skin and soft tissue. After the event happen, 4 days to 4 weeks time, that is called subacute term or midterm. During the midterm, you are getting rodent-related infections like leptospirosis. After that, what happened? During the time of floods, the vectors will be washed away, like the malarias and like the mosquitoes and the mosquitoes larvae. Then once the flood subside, the mosquito larvae has got a lot of places to grow and come back. Previously malaria, but nowadays we are seeing a lot of dengue, chikungunya. Chikungunya is emerging right now. So a lot of dengue and chikungunya diseases are coming up. So we divide the phases into 3 phases: acute phase, midterm phase, and long-term phase. Acute means during the flood, when the water is going on, you are getting gastroenteritis as well as you're getting skin and soft tissue. After the flood water subsides, you're going to get diseases like leptospirosis and respiratory agents. And more than 4, you're going to get the vector-borne diseases like dengue and chikungunya. If you remember these things, it's easy for you to decide what organisms I'm going to deal after the floods. Why people are getting infections? One large number of people are displaced. The temporary shelter is good for food as well as basic needs, but it is not good for infections. Crowding conditions, inadequate sanitations, inadequate waste management. Hygiene is most important thing. Hygiene is a basic thing. And water sources and food, what we are eating in the time of flood, that's more important. So if you think the population displacement, what will happen? The patients goes to the crowded places, flu-like viruses can happen. Stagnant water, leptospirosis. Once the water is stagnating, even after the flood, like a clean water, dengue can happen, chikungunya, Zika can happen. So depends on what sort of activity we are doing during the flight, and after the flight, we are going to stop getting infections is possible. So this is a flood related risk. What are all the activities you are doing? This is a beautiful nature paper I've shown you. How people are getting infected, either because of exposed to the flood water directly, or because of the poor sanitation and hygiene. When the sewage mixes with the water, you are inadvertently consuming it, you are going to get it, or because touching of unhygienic places and there is no place to wash your hands, you are getting it, or sometimes because of the inoculations. That is why skin and soft tissue infections are more common. Rarely inhalations, crowded places, some sick person in the crowded places cough and sneezes you, he can transmit the flu to you. So this is how people are getting in the flooded areas. This is how it can happen. So these are all the roots of infection, and these are all the phases of the flood. So I'll come back to this questions. I walk most of the time. My family walk a couple of times. Who is at the risk of flood? That's the point I'm asking here. So who is at the risk of flood? Not everyone at the risk of flood is going to get the same diseases. So not everyone is same. Whether children is more vulnerable, or elderly people are vulnerable, or those who have got cuts and cracks in the fingers and legs has got vulnerable, or no, water you walk that's more important. Which area you walk is more important. We need to remember in mind. So what are they going to do? Which one is like a more dangerous for you? That we need to keep in mind. So who is at the risk? Usually during the time of epidemic, people say young individual and elderly people, because our immune system is not developed. For children, our immune system is weak. That is for the elderly people. But during the time of floods, people with young, even though they don't have any comorbid, because they're walking in the rainwater, wading in the rainwater, they're taking care of the family. They go buy things, they shift the house, they do a lot of things there. They need to walk in the water. That is why they are vulnerable. If you see what percentage of diseases happening, young individual between the age of 16 to 45, they are vulnerable group. Males are always vulnerable because they take care of the family and most of the time. So that is the reason for it. So people walking in the rainwater, wading in the rainwater, exposing themselves, they are vulnerable to the floods-related infections. Then why I'm talking about the skin and soft tissue infections, even though leptospirosis, dengue, cholera, typhoid, everything is possible, but usually if you see skin and soft tissue infections also coming up, you are staying in the water for a longer time. Once you stay in the water for a longer time, what will happen to your skin? I'll show in a minute. So skin and soft tissue infections also happening, rising, apart from your leptospirosis, dengue, flu, these are the diseases can happening. Nowadays, we are getting one disease called milioid. Milioid is a bacteria like Pseudomonas. So it can cause us a dreaded killer diseases we can call. How leptospirosis killed previously, but now milioidosis is diagnosis is poor. People awareness is lacking. That's why people conducting IMA CGP is conducting about rare infections, not only skin infections, other infections also I'm dealing today. So the skin infections, yes, it's more common. Particularly early part of flood time, people are stagnating in the water, a lot of fungal infections, particularly the Taenia pedis. People stay in the water for a longer time, they develop Taenia pedis. I'll show a couple of figures also there. So cellulitis, people got cuts and cracks, they got scratching because of the irritation caused by them walking in the rainwater or wading in the rainwater, that causes a lot of cellulitis, and other infections also possible. So not only the cellulitis, contact dermatitis. Yesterday also one of the IMA groups, they showed pictures showing the contact dermatitis. And fungal infections, Taenia pedis infections is quite common. Intertrigo, because people are wearing a wet, moist clothes also, they're getting a lot of candidal infections is possible. And people are always keep the water, they cleaning and they emptying the rooms and everything there, they get onychomycosis is also possible. All fungal infections is quite common for people spending a lot of time in the water. Not only the superficial fungal infections, deep fungal infections like telromyces, sporotrichosis, these things also possible. And northeast part of India, histoplasmosis is quite common. Walking through the rainwater or wading or inhalations. Inhalations and dust, lot of what do you call waste has been generated. I'll show in a minute later what are all the waste we are generating and how to handle the waste also there. And mycetoma foot, people walking in the rainwater long, some cuts and cracks, some injury happen, mycetoma foot can happen also. Not only for agricultural job, during the flood time, mycetoma can go up. So not only the superficial fungal infections, the deep fungal infections also possible following different exposure. And similarly, skin and soft tissue infections, not only cellulitis, Taenia pedis is also quite common. So almost other infections like candidiasis is a bit low, but candidal intertricho is quite common. Mucormycosis, depending upon what surface of water you are walking, that is possible there. So this is again candidal infections in the hand. People got submerged or people got cleaning activities or exposure to the chemicals, contact dermatitis and irritant dermatitis can possibly happen. So which water is more dangerous to you? Usually people think seawater, but not seawater. Most of the time, the danger is caused by the fresh water, pond and small lake. That is what we occupied. And the pond and small lake water contains a lot of bacteria compared to seawater. Since in soil contaminated waters, flowing fresh waters like rivers and large lakes has got risk. But what is safe? The purified water, for example, some of the swimming pool, it is not contaminated. The risk of getting infection is a bit low. Where is the infections more? Fresh water has got more infections compared to swimming water. And if you got a wound, for example, if you got an open wound, if you are walking in the rainwater, the chances of wound getting infections is more likely. So two things, what sort of water you are exposed and whether you got wound, whether you got immune system is compromised or not, these things will decide about what infections you are getting it now. How to manage the thing? We need to suspicious very high. If the wound is exposed, we need to clean up the wound. We need to debride the wound. And depending upon the organisms, these are all the common waterborne organisms, Aeromonas, Edwardsella, Vibrio vulnificus, particularly people who got DCLD, underlying liver disease, Mycobacterium marinum, not tuberculosis, this is marinum, then Erysipelothex thruciopathy, Clostridium tetani, Aspergillus species, and Rhizophus. These are all the fungal infections. So depending upon the organisms, we need to start an antibiotic. But the most important thing, whenever some infection is present, if possible, try to debride. That's most important for you. And my second case here, 40-year-old female, diabetic, fever, cough, shortness of breath of 5 days durations. On examination, tachypnea, right side weakness. The WBC count was elevated, polymorph predominant, bilirubin is also elevated. X-ray shows some mid-zone consolidations. Sputum and blood cultures that is showing gram-negative bacilli. Past medical history, our house was invaded with the flood water. She was walking in the water for 7 to 10 days. What is her diagnosis? Fever, cough, shortness of breath, H1N1 or COVID-JN.1 or leptospirosis or hepatitis A, some other infections. Please go ahead and vote. So we can see 475 people I'm seeing there. So how many people are able to answer this one? Just check. So this is a post-test possibility because you are getting a credit points on the TNMSC. So please go ahead and vote. What do you think about it? This lady is a diabetic, fever, cough, shortness of breath, X-ray showing some patch. I see 4 responses out of 475. People say this is leptospirosis. My previous speaker alluded. Some say this is some other infection. They want to know what is some other infections. So in flood, what happened? I'll just show in a minute what is the flood-related infections. Before 2005, when a person walks through the rainwater, getting a jaundice, getting a shortness of breath, you put your money on leptospirosis. Leptospirosis is more common. But from 2009 onwards, if you see the milioidosis, this is a skin bacteria, soil bacteria present in the soil and water sources. So the climate also plays a big role, like rain and everything. Who will get it? I'll show in a minute later. People who got diabetes, people who got kidney disease, people who are alcoholic, if they got walking in the rainwater, wading in the rainwater, doing a contaminated surfaces, the milioidosis is now growing up. So what is the reason? Inoculation is common reason. Inhalation is also possible, rarely injections. So we need to avoid contact with rainwater, particularly people with comorbid conditions like diabetes, CKD, alcoholism, they need to avoid. Otherwise, the chances of milioid is very high lately. This is a paper we wrote in 2012. This is a paper we wrote the paper in 2012. That time only the milioid started emerging. We published in JAPI, the Journal of Association of Physicians of India. So what we are telling it, so these are all the risk factors, particularly people diabetic, people alcoholic, CKD. If you got a cavitating type of pneumonia, consolidations, abscess, put your money on milioid. But we mentioned trauma is also one of the risk factors. Trauma is also one of the risk factors for it. And we got a abscess, particularly splenic abscess, prostatic abscess, parotid abscess. Think about this bacteria. Then what about the flood and milioidosis? During the flood, this is paper from Malaysia. Usually it is common in Bangkok, Thailand, Malaysia, India, Australia, milioid is more common. And if you see, whenever the rain happened, milioid numbers is going up. So this is the data from Malaysia. I showed the data. When the rainfall is more, the chances of milioid is going up. When it is a flood, the numbers is double up. So this is the risk of getting milioidosis. So milioidosis means the rain. Rain and trauma, the increases of milioidosis can happen now. So this is a paper we saw in 2015 Chennai floods. What we saw, usually milioidosis, we rarely see a couple of cases of milioidosis. But after the event of Chennai flood in 2015, we saw a lot of milioidosis. This is a tip of the iceberg, what we see. Particularly, the patients can have 5 days to flood for 14 days. After the exposure of flood, they can develop a lot of milioid. It can present as a severe pneumonia. It can present as a brain abscess, prostatic abscess, and almost sepsis-like picture also can happen. It kills the patients. If you fail to recognize that drug of choice is meropenem or ceftazidime initially, followed by cotrimoxazole or doxycycline. This is our cluster we presented in 2015 after walking through the river water. This is within 2 months. We saw a lot of cases, 12 cases in 2015, and we put our data. Our mortality at that point of time is 33%. Despite good knowledge, we didn't save all the patients, so people lost a life. So whenever you think leptospirosis following floods, think bilioidosis. That's a take-home message for you. Now, my water has receded. Lot of water entered my house. How to clean my house? That's the other big questions people will ask you. Even though this is not a doctor to answer, but as an infection control and infection prevention doctors, we need to know. A lot of offices invaded, even hospitals, nursing home. A lot of mold will exposure. You got a smell. When you go an invaded house, the smell will kill you. So how to do it? These are all the people should not expose to the mold. Pregnant people, asthmatic, people who got immunosuppressed, don't expose to the mold. We need to get away with mold, and we need to wear proper PPE. Not only COVID needs proper PPE, cleaning the house after the floods also need a lot of input. So we need to wear at least mask, the surgical mask, ideally N95, because aspergillus and everything is an inhaled spore. If you are immunocompromised, don't do this type of cleaning activity. Ask someone with immunocompetent to clean the activity. And as much as possible, we need to throw away whatever things is there. So a lot of infection control issues after the flood is also playing around. So we need to protect yourself. That's more important rather than cleaning the items. Take care of your health. That is more important. Then this is happening. I've stayed in a shelter. 2 days to the shelter. A lot of inmates now develop diarrhea, suspicion of cholera. What are going to do? Vibrio cholerae, they're suspecting. So what vaccines during the time of flood? Yes, these are all the diseases transmitted by the water, but during the outbreak, we need to prevent how to prevent the floods people are talking about. But before floods, during floods, and after floods, ideally before floods itself, we need to take typhoid vaccinations if the risk is high. On the time, during the time of cholera outbreak, apart from cleaning our hands, apart from taking a pure water, washing frequently our hands, we need to take certain vaccinations also. For example, if there is an outbreak of cholera, today, Orissa, they got an outbreak of cholera there. I do not know whether it's a flood related or non-flood related. Whenever some outbreak of cholera happening in the community, we need to give a ring vaccination surrounding the people. So Vibrio cholerae vaccinations needed if you think some outbreak is happening in your country or in your part. So these are all the vaccines during the disaster time itself we need to administer, particularly people keeping the shelters. They need to do this disaster. So I'll come back to my last case here, 60-year-old male, diabetic, fever, cough, shortness of breath. Recently exposed to the flood, stayed with other residents because the ground floor is flooded. So they went to the top floor, all the residents stayed together. On examinations, febrile saturation is 88%, WBC count is normal, bilateral infiltrate, throat swab for H1N1 is negative. Start some antibiotic, please go ahead and vote again. See this last case. Towards the end, how many people are active? I just want to check. So what do you think for this patient? Whether you want to start some antibiotic or symptomatic care or CT chest or do viral panel or all of the above. When MCQ says all of the above, people always got tempted to do what to do there. So say symptomatic care. This is like something like a simple viral infections. I give symptomatic care. Thus will take in care. Couple of months back, people are worried about November means when China coughs, sneezes, people are worried. They call walking pneumonia. What is walking pneumonia? Usually Mycoplasma pneumoniae make the patient sick. They walk Mycoplasma make the person little oxygen dependent, but it won't make the person sick. That's why most of the children, they got oxygen, they're writing the examinations. If you see the pictures in the Facebook as well as in the social media, children in the China, they suffer, but they're still going to the schools, going to writing the exam. That's called walking pneumonia, it's called Mycoplasma pneumoniae. But what happened in November, we do not know. But what is happening in the entire world, we do not know. Whether China is the source again, people are worried about it now. So when China sneezes, the entire world is coughing. WHO is giving attention, something is happening in the China, please investigate. They don't want to waste it. China sees all sorts of things there, Mycoplasma pneumoniae, RSV, influenza, little bit of COVID. So not only China, the disease is transmitted to the South Korea as well as Vietnam, couple of Mycoplasma pneumonia happened. But what is happening right now, COVID is on the rise. I'm start seeing cases COVID. The initial call for us is when doctors getting some symptom, they used to call me there. Right now, I'm seeing 3 to 5 cases of COVID per day. So we are initial tick, but we do not know whether it's going to upsurge like Omicron or whether it's going to behave like a Delta. We do not know. This is Omicron variant. People already infected, people already vaccinated, Unfortunately, vaccination is now available, not available. So during that time, if it is surge happening, what we need to do, wear your mask first. That's what the Telangana State Society give asking the patients to wear masks. And we need to close surveillance means whether it's J.1 or whether it's COVID, COVID is always COVID. So wear mask. If you are able to get some vaccination as a booster, according to the government of India, we need to take the booster also. This is one of the institute. They ask all the attendees as well as all the patients to wear masks. The policy is again back. The number is slightly, not slightly, but for me, last couple of days, I've started seeing daily 3 to 5 cases of COVID right now. So COVID is on back. So we need to be prepared. That's why Government of India send notifications to the healthcare organizations, be aware of it. Definitely, but we need to closely monitor how far the COVID is going to surge. And this is a relationship between the floods and COVID. I saw this paper from the Romania. They're saying whenever flood happened after 2020, they correlated COVID is going up. Either because of the close stay or because what is the reason for people are excreting the COVID. Right now, if you see the wastewater, almost US, Europe, all wastewater showing a lot of COVID. Whether because of the fecal excretions and exposure to the wastewater, we really do not know. But following the floodwater exposures, COVID has gone up in Romania. I just showed this paper to you. So following flood, COVID also can go up. And what is the management as an outpatient? The patient does not require oxygen, but the patient has got a lot of comorbid conditions. It's called Nirmaltravir plus ritonavir. That's called Paxlovid in US. India, it is called Nirmacom. 3 tablets in the morning and 3 tablets in the evening for 5 days we need to take. When there is no oxygen requirement and the patient has got multiple comorbidity, you can prescribe this Nirmacom as a trade name, but the medicine is Nirmaltravir plus ritonavir. If the patient is hospitalized and oxygen dependent, we need to start remdesivir along with steroid dexamethasone 6 milligram to 8 milligram once a day, along with anticoagulants. So this is a protocol we are following it up. Hospitalized patients, when a patients require oxygen or hospitalized for some other reasons, we need to think about starting with the Nirmacom. Nirmacom is Nirmaltravir plus ritonavir, 3 tablets in the morning and 3 tablets in the night. So this is why the government of WHO's recommendations, they still recommend Nirmaltravir and still they recommend remdesivir and steroids. Molnupiravir is a number 2 choice. Still, Molnupiravir is also available. The monoclonal antibodies are all gone. So this is a drug available in Paxlovid. This is how the pack will be there. 3 tablets, morning 3 tablets, evening 3 tablets. But Paxlovid is not available in India. Other brand generic is available. So if you got COVID, the patient is sick, the patient is comorbid conditions, you need to give these medications. So how the J11 is going to behave, people are think the corona is confusing wonder. We got facing corona for the last 4 years, but still we are getting confusing only there. And ID doctors are closely monitoring what is going around in the country, going around in the world. We'll keep you posted. Suppose we needed IMA CGP, we can update you shortly about what is happening in the JN1 in a couple of days with the help of our team, Navinathan, and IMA CGP. Right now, masking is needed. Rapid home-based COVID testing is also required. Rapid testing required. And we need to screen the wastewater surveillance also and genomic sequences to find out whether it's JN1 or whether some other lineage. Last but not least, COVID vaccinations. If it is available, we need to take 1 shot as a booster to protect for next couple of months. And we are creating a dedicated WhatsApp community. This is one of the questions asking one of the IMA groups. One of the child walked in the rainwater, developed the skin reactions. What do you think? And people are asking about how to use antibiotic like tigecycline, minocycline. Other is asking how about the rabies. I have already taken vaccinations 1 year back, again dog bite. So all ID related things, you can have a best of IDs WhatsApp community. This is called curbside consultation. This is free only. Only thing you need to shoot up to this number so that you can get the answers. So just shoot your questions and you can get clinical questions. It's free of services only, because during the sessions we teach a lot, but after the sessions you can forget. So keep this number so that we can have any practical challenges to you. We can solve the thing there. If you want official also, it's possible. Unofficial also possible. We can send it there. So this is you. Thanks for the wonderful opportunity. Happy to take a couple of questions there. We are running on time, but we can open for a couple of questions there. Thanks for the wonderful opportunities. Any questions?
I request our members to put your queries, especially the last topic, which is skin-related infections. It is a wonderful CME. So Sir, you can also put some commonly asked questions there.
Okay, no problem. So people
Yes,
commonly
sir.
asking COVID is common or not. Yes, COVID we start seeing again there. So be careful because we can't test influenza right now. Previously, my test positivity influenza almost 90 to 95% of the time. COVID is very, very rare. After the last 2 weeks, the number is almost 60% influenza, 40% COVID is turning positive. We can't do the influenza testing as outpatient testing, but COVID we can do outpatient testing. What is a new symptom again like wave 1? What is the wave 1 symptom of COVID? Lack of taste. So please ask your family, any patients present with fever, cough, sore throat, please ask lack of taste again. The lack of taste is one of the common symptoms we are encountering now. So lack of taste and body pain and back pain is this time severe. Some amount of diarrhea also encountering. So these are all the symptoms you need to think about it. Any person, particularly people visiting a crowded places like pilgrimage like Sabarimala or Tirupati or some other places where they went, crowded places, came back, ask the history of fever, cough, sore throat, lack of taste, back pain and diarrhea. Think about it.
Yes, sir. Sir, there's a question, sir, from
Sure.
Dr. Ron. Yes, sir. Do you still recommend this antigen swab test, sir? Is it advisable for a
Yes.
rapid testing of COVID?
Yes, right now, Naga, for a small setup, if you don't want to do the thing, the rapid test. But again, one of
Yes,
the
sir.
small hospitals, they did the thing. Rapid test, the pickup rate is low. That means the sensitivity of rapid test is not great. But rapid
Okay.
test is positive, it is highly specific. That means true
Okay.
positive. The person is in
Okay.
infectious period, he can transmit the diseases. So you need to know how to interpret the rapid test. Positive or negative does not rule out COVID.
Okay. Then one more question, sir. Suppose if we take up the previously when in the era of COVID during the second wave when we took up the patient for surgery, we all did RT-PCR confirmatory. Then if it was negative, then we went for the surgical report. Is it now necessary to follow the same for elective general anesthesia surgeries, or it is not necessary, sir?
Next couple of weeks, Naga, maybe yes, I can say that because the number is slightly because we are seeing only tip of the iceberg. We are not testing frequently, as you rightly pointed out. Before
Yes.
all surgeries, before all procedures, we tested more even. But right now, we
Yes,
start seeing cases means definitely one case of COVID means for me the minimum 25 to 100 cases maybe in the community. What we are seeing is only tip of the iceberg. So I think
Okay,
for
sir.
major surgery, not for every chota mota surgeries, for major surgery, I think general surgery, we are seeing because following post surgery, couple of persons turn positive in our hospital. So we need to think
Okay,
about
sir.
it. So next
Yes.
couple of weeks, yes, but we need to closely monitor. That's why I said one pictures I put. ID doctors are closely monitoring what is going around. So it's very difficult to predict the corona. This slide, that's why I put it. So we are monitoring
Yes,
closely what is going around. So next couple of weeks.
It's a good question, doctor. Actually, we are doing lots of scientific scrutiny for the virus because
Yes,
very
sir.
difficult to, as rightly said by my colleague Suresh, we are what we see is only tip of the iceberg. For every case
Yes, sir.
that has been detected, there are more than 25 to 100 cases that are under the bottom of the water. So, so when you are doing a major surgery, it is better to subject to RT-PCR and then take them.
Yes, sir. Thank you, sir. Sir, and sir, any questions you can just moderate, sir. There are some questions in the chat box as well. Yes, sir.
Yeah, you can just see the chat box and ask Sandil. For those of you who are joined late, we had discussion on AGE, jaundice, typhoid. We had discussion on lepto, COVID JN.1, and we had discussion on flu. We had discussion on dengue. We had discussion on various skin diseases, including melioidosis, which is a new rare disease that we may come encounter in Chennai. Yeah.
About COVID vaccination advice in children, they're asking, sir, in the chat box.
Yeah. Because as of now, the vaccine is not available in pediatric age group. Government has withdrawn. As soon as you get it, you will be giving. As of the government directory, there is no advisory directory to start on revaccination. Now they are constantly keeping a constant vigil on the outbreak of JN.1. It's now seen in 4 states, particularly Kerala, Karnataka, Maharashtra, and Jharkhand. In India, in Tamil Nadu, we had one case, a person flying from Singapore, landed in Trichy. They immediately caught hold of him. He was isolated and then we have stopped spreading in Tamil Nadu. But bordering districts, we have to be very, very careful. But one good thing about disease is that it is, though it spreads fast, It's not a major disease. Mortality, morbidity is very low. The mortality so far has been seen only in patients with comorbid conditions, particularly in pediatric age group. Mortality is practically zero. So at present, we'll keep a constant vigil. And particularly doctors who are attending this meeting, I request all of you to wear masks from today itself, and then to take a flu vaccine also from as far as possible, as early as possible. Preferably now we got that Northern Hemisphere vaccine, 2023 vaccine. I request all the doctors to take a flu vaccine.
Sir, there is one question.
Yes, sir.
Yes, sir, proceed.
So the PCR, they are asking for the PCR help in the diagnosing infectious diseases. Yes, PCR will help in diagnosing more of the infectious diseases. It is not only for COVID, even the nucleic acid-based amplification test for TB is also PCR. PCR, nothing but we take one copy of the bacteria or virus and multiplies, and we see whether the genome is present or not. So it helps in diagnosis of COVID. It helps in the diagnosis of tuberculosis. Apart from the influenza also, this is H1N1 also is PCR test. And even for other things like leptospirosis, now PCR is available because serology is always confusing there. So leptospirosis PCR available, chikungunya, dengue PCR, even typhoid PCR. These are all available right now in Tamil Nadu. So if you think the patient has got diagnosis, you can't made based upon the serology, because serological test, the interpretation is always challenging there because a lot of cross reactivity can happen, and sometimes the serology can remain positive for longer time. PCR again, compared to serology, it is better, but gold standard is always culture. But culture take time, availability is challenging. PCR is a shortcut for the culture, but we need to know how to interpret the PCR also. For example, during the time of COVID wave 1, that time we need to get 2 COVID negative PCR, then only we can discharge the patient. That's what created in March 2020. What happened? I got a patient submitted in March 2020 till May 2020. I can't discharge the patients. Patient is clinically stable, but the PCR was remained consistently positive. So the PCR can pick up the dead bacteria, dead bacteria, and dead viruses. And sometimes out of it, it's very difficult to differentiate dead. PCR always take with pinch of salt, but compared to the serology, PCR is much better. Compared to the blood culture, PCR is slightly inferior.
It's a good thought-provoking answer from Suresh. In pediatric age group, when you take a throat swab, particularly for viruses, PCR is very good for influenza, RSV, human metapneumovirus, COVID virus, and it's a good for pertussis. All these things you can take a throat swab, but it's PCR. The throat swab is not good for pneumonia because many times you get common salts in the throat, and then that will not be a good reflection of a lower respiratory tract infection. That's a message. And the second thing, as rightly told by Dr. Suresh, PCR may remain positive for months even after the disease has been cleared. In the dead viruses, dead bacteria, the circulating will be picked up by the PCR and it will show us positive. So it's good for diagnosing sometimes even after clearance of the virus and bacteria, PCR will remain positive. That's another point that you need to keep in mind.
Sir, there is one question. Yes, yeah. Sir. There is one question. Vidal, is it still significant and relevant?
Please, Vidal is not a good test to be done. Please ignore Vidal. Vidal is not at all recommended by ID. So I think better stop using Vidal. And if you do Vidal, please do it after 7th day. And please do only tube method. Do not do slide method. And sometimes, many times, lab technician underlines Vidal positive 1 in 40, 1 in 80. And then just looking at the 1 in 40, 1 in 80, do not tell it is Vidal or the early stage of Vidal. To say it is Vidal, O and H both has to be positive for more than 1 in 160. So never say Vidal positive just because the lab technician has underlined. As far as our IAP ID is concerned, Vidal is a test that has to be ignored. So never use Vidal in pediatric practice.
Test of historical interest.
Okay, sir. One more question, sir. How long the flu vaccine will work? Like, how long is it effective?
Yeah. As I told you, there are minor antigenic drifts that happen on the envelope of the virus. That is called drift because viruses keep changing. There are 4 strains at present circulating. All the 4 strains are there in the vaccine present 23-24 batch. So by around April, May of next year, 24, we'll be getting Southern Hemisphere vaccine. That vaccine will represent the strain that is prevalent in the 2024 for the because viruses keep changing drift of envelope. So the vaccine that is available at present will cover the strains that is prevalent now. So next year, as it keeps changing, the newer vaccine will give protection for the next year strains. So I think you need to take, if you have got comorbid disease, or the recommendation, as I told you, from children from 6 months of age to 49 months of age, children with comorbid disease or immunosuppressive disease or on steroids, children with obesity or pregnant mothers or adults more than 65 years of age with other comorbid conditions like asthma or COPD or diabetes, all they have to be given preference and they have to be vaccinated annually. That's a very, very important thing. And it can be concomitantly given with other vaccines. Even with persons with epilepsy, with caution, you can give it.
It's usually valid for 1 year, sir, because the viral drift can happen and the northern strain is available in September. Our winter also started in the month of September. So usually we administer September every year. So that when the winter season starts, we prepare for your immunity system to tackle the respiratory system. And usually I admitted previously, as Saz said, like a comorbid people, but everybody can supposed to take. For an adult, if you take a vaccinations, what is the benefit? It may be cough and cold for you, but if you transmit the diseases to elder or younger one in the child in your family, they're going to suffer. So for the sake of elder, for the sake of younger one, everyone's supposed to take. So everybody's supposed to take annually 1 shot, because otherwise the virus keep changing there. Some people say last year strain is same strain is circulating. Can I skip this year? Ideally, it has got not long-lasting immunity like COVID vaccine only there. So we need to give a booster September. Every September is supposed to take.
Sir, there is one question. Why conjugate typhoid vaccine is not recommended above the age of 45 years? I think they had this input in one of the CME.
Sir, no, usually the typhoid vaccines, because the age group vulnerable for typhoid is children, adult and adolescents, children, adolescents, because the eating habit, if you see, most of the time typhoid is a foodborne disease. So people are eating outside food, whichever food is not cooked, not boiled there, and children, because they keep their hands in different places and start eating without proper hand wash and hand hygiene. So that is the reason for it. But after the age of 40, because multiple times exposures in a developing world, some amount of, even though it is not a lifelong immunity, but people got some amount of inherent immunity can develop because of the either sublethal doses of exposures or multiple exposures in the past that protects them there. So usually, but there is no absolute contraindications. We are giving the typhoid conjugate vaccines, particularly for transplant setting, liver transplant setting. We are giving it not for the renal transplant, liver transplant, because it involves the gut part also. We are giving a transplant vaccinations or whatever it is. There is no absolute contraindications above the 45 years. I don't give it. The risk of getting typhoid after the age of 40 or 45 is going down because of the repeated exposures in the childhood as well as adult and adolescent side.
Fine, sir. Sir, there is one request from the audience, like they are in requirement of the flood-related infection slides, because it is very relevant in the right time.
Yes, sir. We'll give you those who want these flood-related slides. You can send your request to my personal number 98422 98422 11179. I'll send all the slides to you. I request all of you to share the slides with your branches so that everybody, even those people who did not attend, get benefited. Because knowledge is something that we need to spread it across the entire Tamil Nadu. At this juncture, I like to appreciate Dr. Sendil for taking energetic steps to spread the knowledge across the entire Tamil Nadu. So you can send a request to me 98422 11179 11179. Send a personal request to me.
Yes, sir. Thank you, sir. Sir, and there is one question.
I already shared my slides, so please feel free to share.
Yeah.
Fine, sir.
Yeah,
So there is one final question, sir. Like, how long the flood waters takes time to contaminate? Like, how long it is relatively safe, and when it becomes very hazardous? What is the time duration they are asking, sir?
I check the data, sir. That depends upon the what type of contamination is going to happen there. For example, if the sewage mixed with the water, it starts contaminating immediately there. So what
immediately? So in case it is not contaminated with sewage water, only it is a flood water. So from which day it becomes very hazardous, sir?
So usually the time progresses, chances of getting contamination is more. And second thing, not only the sewage mixing, even the what I said, mixing with the soil, because our soil also
Yes,
contains
sir.
a lot of bacteria. So once
Oh.
the rain is pure, once it falls on the surface, it is got impure. So I looked in the data, what is the time period it is safe up to, we can walk, and afterwards the risk is going up. There is no specific time limit they mention about it.
Fine, fine.
Because once it falls on the soil contains a lot of bacteria and microbes. So it gets contaminated. But the risk of getting infection, how long you are walking, and whether cuts and cracks, whether you're immunocompromised or immunocompetent. These are all the factors that decide it.
So for
Thank
the carrying of message is any flood water is infected water. That's a message.
Fine, sir. Yes, sir. Sir, and at the outset, we just want to inform you all that we have just touched the 1,000 registrations for the CME today. So it is the highest for the any one-day event CME, and more than registrations, I think we have 200 to 300 people who have attended more. So we'll come with the exact data. So the credit goes to all the speakers and the topics today. So it is very much interesting and relevant for the today's scenario. So we thank all the speakers, and also we would like to inform you that the new team of CGP IMA TNSB has taken the charge. So myself being the Director of Studies, Dr. Anand being the Secretary, and we have joint secretaries, Dr. Suresh and Dr. Sengodan, and we have CGP representative, Dr. Madan Mohan and Dr. Gopalakrishnan, and CGP Governing Council members, Dr. Tirumurthy from Pollachi and Dr. Vivek from Hosur. So we have a big team, and we have all zonal representations. Any queries you can ask them. We'll share all their numbers. And this month, from this year, we are going to increase some new courses and also increase the strength of the existing courses. We need all your support. I request all our members to become a CGP member and of course IMA member. So, and also we have our convocation. I request our CGP Governing Council member, Dr. Tirumurthy sir, to give an invitation to all our members to attend the CGP convocation along with the CME.
Dear members, we have our TNSB GCP convocation on January 7th, Sunday, 10 a.m. to 1 p.m. at Tambaram State Office. I request all our GCP course members to attend the convocation, and also I extend my warm welcome to all IMA members who are in Chennai. We have arranged a wonderful CME also with this program. Thank you.
Yeah, thank you, sir. Sir, anything to be discussed, sir?
Nothing, sir. Nothing, sir. I thank
Yes,
all
sir.
the delegates who joined the meeting. My sincere thanks to Dr. Ravi Shankar, Dr. Suresh Kumar for being the
Yes, sir.
speakers. Sincere thanks to Sendil and team. Sincere thanks to Dr. Tirumurthy, who is always sitting by the side of Sendil. Always. Thank you. Thank you, everyone.
Thank you, sir. So now I request
you, sir.
our Secretary, Dr. Anand sir, to give a few conclusive remarks and followed by vote of thanks by Dr. Madan Mohan.
Yes, sir. Yes, thank you, Sandil. Sir, good evening, sir. It was indeed a very good CME, but actually the CME was planned for the floods in Chennai. But after that, before the CME, we had a very good, more than a devastating flood in the south. And now it is starting to rain in the middle of Tamil Nadu. So I think this the number of attendance in 1,000 in this case is because of that. And it was really wonderful and it was very informative, sir. I would like to have your support in the coming years also, sir. So we'll definitely plan another thing, sir. Thank you very much, sir. I would like to thank personally Dr. Ravi Shankar, who joined us in the last moment because the other speaker was not able to attend. I would like to thank Professor Neminathan, sir, and Dr. Suresh Kumar, sir. Thank you, sir. Thank you very much, sir.
Thank you, sir. Now I request Dr. Madan Mohan to give a vote of thanks. Fine, I think Dr. Madan is not. Yes, sir. Kindly come, sir. Yes, sir.
Good evening, everyone. I'd like to take this opportunity to thank IMA TNSB and CGP for giving me this opportunity to propose the vote of thanks for the first CME of the CGP. I would like to thank the speakers of the day, Dr. Ravi Shankar sir, Dr. Neminathan, and Dr. Suresh Kumar sir, for their excellent talk and which is eye-opening for many of us. So I would like to thank the felicitations given by the State President-elect, Dr. Sengutuvan sir, Dr. Jayalal sir, our past National President and Secretary General of Commonwealth Medical Association, and all the CGP Governing Council and the CGP members who have joined this. I will be failing in my duty if I'm not thanking all the participants and all the delegates who have joined for this wonderful CME. Thank you one and all for this opportunity. Thank you. We will be coming up with more CMEs in the future. I request everyone to join for the CMEs which IMA, TNSB and CGP are conducting. Thank you one and all.
Thank you, sir. Thank you, sir.
Thank you.
Thank you. Thank you, sir. Yes, sir. Bye, sir. Thanks for your time, sir. Yes, sir.
Thank you, sir.
Yes.
Thank you.
Thanks, sir. Anand, sir. Thank you, sir.
Thank you, sir. Thank you,
Yes, sir.
Tirumuchi, sir. Thank you,
Yes,
Father.
sir.
Thank you.
Yes, sir. Thank you, sir. Thanks.
Bye.